Well, good evening, everyone. Welcome to Community Medical School. This is the third session of this semester. I'm Virginia Hood. I'm a nephrologist, a kidney doctor, physician, and a professor in the Department of Medicine at the University of Vermont and Fletcher Allen Healthcare. And it's a particular pleasure for me to introduce this session tonight. Firstly, because I'm very enthusiastic about keeping blood pressure in check. Control of blood pressure is the most effective way we can reduce the risk of stroke, heart disease, and the progression of chronic kidney disease, my special area of interest. Secondly, I'm a huge advocate for people participating in their own care. So it's a real delight to see so many faces here wanting to become informed about their care, and especially in an area where your individual contribution can make a real difference. Thirdly, and most importantly, you will hear about the science and art of blood pressure control from a master educator and highly skilled storyteller. And this is really the delight of the evening. Dr. Alan Segal has been a colleague of mine and a colleague of ours in the nephrology unit at the University of Vermont for almost 20 years. He's a native of Chicago, and interestingly enough, his first degree, academic degree, was not in medicine, but in electrical engineering. But it was this interest and these experiences overlaid on his medical degree that took him on a journey into trying to understand how the kidney regulates the chemicals and fluids in the body, which are really key for all of our general well-being, and particularly about blood pressure control. And he has sought answers to these questions over the years in research, and has published papers locally, nationally, and given presentations on this subject. But it's not just this scholarly activity that drives him. His real passions have been teaching and patient care, and he excels in both of these. He's always curious, sometimes iconoclastic, but always thinking outside the box. So you're in for a real treat tonight, and it's a great pleasure to introduce my colleague and friend, Dr. Alan Segal, who's going to talk to you about keeping blood pressure in check.
Well, that's probably the nicest introduction I could ever imagine. And I'm very happy to be here tonight because this is the first medical school that ever accepted me. So the fact that I got into community medical school is fantastic. My parents are very proud. The other thing is I brought two talks with me tonight, depending on the audience. One was for the advanced students, and one was for the geniuses. And looking out on the crowd, I can see I'm going to give the genius talk tonight. So this is the genius talk. And as Virginia said, I didn't recognize who she was talking about at first, but boy, that's a pretty nice introduction. And a lot of what I've learned about blood pressure, I've learned from Virginia and my other colleagues in nephrology. So this is really kind of, you're hearing from the group of nephrology here, except for anything she doesn't agree with is my responsibility. As I was putting this talk together, I realized that the more I looked into it and the history of blood pressure and high blood pressure, the more it was interesting that it was looking like we might not have come so far. So I'm going to try to weave several themes together tonight as we go through this. So the first introduction is just to let you know how big a problem hypertension is. It's a major public health burden. There's probably about 1 billion people in the world right now. They're estimated to have hypertension. It's more pervasive in the Western world, and it's the single largest contributor to death and disability worldwide, and it's something we can all know about. It's, as Dr. Hood mentioned, it dramatically increases the risk for stroke, heart attack, heart failure, and chronic kidney disease because humans and in general biological organisms don't like things being at high pressure. There are very few examples where high pressures are desirable in a biological system. There's good reasons for that because pressure can hurt things. And as I'll try to show you, the physiological systems would much rather have high flow at low pressures, but sometimes things don't go the way they ought to. And there must be a very good reason for us to have a high pressure system in our body that eventually, at this stage of the game, could actually damage our tissues and our cells. And I guess for a long time, we've come to the understanding that once blood pressure rises above 115/75, where this is the systolic, where the heart contracts, and the diastolic blood pressure, it seems like cardiovascular mortality seems to double for every 20 millimeters you go up in the top number and every 10 millimeters you go up in the bottom number. And so physicians have been guided through the years to try to keep people, and first identify, is there a number that's the right blood pressure to be? And if your blood pressure is clearly elevated, how can we get it down safely and without side effects to reduce people's risk? So here's just an example that shows you why this is such a big problem. This is stroke on the left side, ischemic heart disease. And what it shows here is that as you look at ages, and these different lines are different decades, people in their 50s, 60s, 70s, and 80s, you see the mortality. Now, of course, there's going to be more mortality at baseline, given the fact that as you get older, it's more likely you're going to pass away. But look at the almost linear relationship with these complications as the systolic blood pressure goes up by just 20 millimeters of mercury. For both stroke and heart disease, it doesn't matter how old you are once you're above the age of 40. If the blood pressure goes up, your risk for mortality goes up. And this is what we're trying to curb. Now, hypertension in the United States, a couple of fun facts. It's the most commonly diagnosed condition in the United States. It's the most common reason people go and visit a doctor. There's about somewhere between 72 and 74 million Americans who have hypertension. It makes you feel almost like it's almost a majority. If 74 million people voted for president for the same person, that person would become the president of the United States. Over the years, we've had improvement, though. There used to be, I'll show you, that people weren't always aware they had high blood pressure. Nowadays, things are better. 82% of people are at least aware that they have high blood pressure. Their doctors told them or they figured it out on their own. And this is up from 2 out of 3. 75% are getting some sort of treatment for their high blood pressure, which could either be lifestyle modifications or drug therapy or other therapies. And we actually celebrated the last time, when finally over 50% have their blood pressure under control. So the fact that we celebrated when it was over 50% tells you that the number of people that have had their blood pressure controlled over the years has not been ideal. And it's not only is it 74 million Americans who have it, it costs about $74 billion in terms of the burden for the complications that relate to high blood pressure. So it's a very expensive and very devastating problem. So I wanted to go into sort of the history of all this. Where did this all come from and what do we know? So to give you a very brief history, it looks like about 2600 BC. The Chinese, of course, were the first to probably notice it. We've all been told if you think you've discovered something new, it's because you don't read Chinese or German. And so it's probably no wonder that they discovered it first. And it took a very long time from 2600 BC until the 50s when we really had the first medication that was tolerated well for the treatment of hypertension. And you'll see it wasn't so long ago in the 20th century, at the beginning of the 20th century, that patients were being treated with venesection, that is bleeding to lower their blood pressure. Not exactly the most advanced or finesse approach. So I guess where did we start with measuring blood pressure? It's astounding to me to think about that it wasn't until 1733 that a blood pressure was actually even measured. Again, this is probably the way that you guys were measuring your blood pressure at home. You lay down, and one of your family members holds you there while a tube is put into your carotid artery. And then somebody measures how high up that pressure goes. So this was a Reverend Stephen Hales, who in 1733 laid a horse down and put a pipe into the carotid artery and was able to measure the pressure as a column of blood and could estimate what the pressure was. So it wasn't that long ago. This is, not too long before the revolution. So this was invasive. It was inside an artery. There was a risk of infection. He's not even gowned, and he's not wearing gloves. And so this is probably not the way to do it. But at least we started to get ideas of what the blood pressure was. And human blood pressure wasn't really recorded until 1847. But they did have the typical medical school approach to teaching here. So this is the student, and this is the professor. This guy is wondering why he takes care of horses. He should have gone to med school. So anyway, the history is not that long. You just have to start just before the revolution to see about the history of blood pressure. Now, a very big advance was when we had a way to measure blood pressure with what you see here is an old, probably not the original, sphygmomanometer. So in 1881, Samuel Siegfried Karl Ritter von Bosch, he was from Vienna. He was the first to use a sphig to measure systolic blood pressure. It wasn't a very great design, and so these folks figured out a better design in 1896, improving on von Bosch's design. And in 1905, a big breakthrough was made when Korotkov, a Russian physician, made the discovery that you could use the sphygmomanometer, and by placing it on the arm and listening to sounds, you could discover the sounds that were associated with detecting the systolic blood pressure and the diastolic blood pressure. And we still call those the Korotkov sounds. And we still listen for those using our stethoscope to figure out when the systolic and diastolic occur. You pump up the sphig until you've occluded the brachial artery. You release the pressure, and when the pressure is high enough to overcome, the systolic pressure is high enough to overcome that you can hear something again, that's the systolic blood pressure. And when you stop hearing noise, that's the diastolic pressure. So here is actuarial data from 1925. Insurance companies were the first ones to jump on blood pressure. So again, blood pressures weren't really measured until the early 1900s, but already in 1925, insurance companies figured out if you had high blood pressure, you were going to die early. And so actuaries wanted to know these things. And so for the people who were insured in 1925, you sort of see this distribution of blood pressure, the systolic on the top, and it's sort of Gaussian. If they would have had more members, you would have seen more, it would have looked more Gaussian. But you see things seem to center around 130 for the systolic millimeters of mercury, and about 82 or 85 for the diastolic. And I still think that this is probably, if you were walking around with this kind of blood pressure today, we would think you were doing pretty well as long as you weren't having symptoms. This is especially the blood pressure that's going to be recommended, we've always recommended for people with chronic kidney disease or diabetes. We always thought they needed a little bit of a lower blood pressure. So these blood pressures in 1925 would have been considered probably healthy then, and we'd probably consider them healthy now. Although, as Dr. Hood is quick to point out, we have no real conception of what a blood pressure, what the number ought to be. We know how to move it, but we're not really sure what it ought to be. And I'll show you that. This same kind of actuarial data from 1925 also showed that when they split out the men and the women, and they split out the age groups, that you saw that clearly blood pressure increases with age. And this was a big problem, I think, because for decades, doctors were trained in medical school. They saw this slide, and it was sort of like, here's what happens to blood pressure. So it was sort of like when doctors would then go out and practice and would see their patients getting older and have their blood pressures go up, they would say, oh, it's just like the slide in medical school said it would be. They're getting older, their blood pressure goes up, that's good, they're right on schedule. This was the problem. The problem was this is what isn't supposed to happen. So my own personal view of it is that blood pressure is one of the several vital signs that we measure. You go to your doctor, that doctor measures your vital signs, your respiration rate, your pulse rate, your temperature, and your oxygen saturation, for example. These are all things that are supposed to stay constant through your lifetime. So you're supposed to be 37 degrees centigrade or 98.6 Fahrenheit temperature, and that's your temperature for your whole life. It's supposed to stay stable. The blood pressure is the only vital sign, apparently, that's allowed to have gone up like this throughout life. And it may be that this is one of the problems. Maybe we shouldn't let this happen. Maybe it should be kept at a steady state, and that maybe your blood pressure at 18 or 25 ought to be the one that you stay at for the rest of your life. No one's ever really tested this hypothesis, but it's interesting now that we could actually do it. So another very influential guy was Sir William Osler, who is well known to everybody in medicine, started the Johns Hopkins Medical School, and basically is single-handedly responsible probably for the way medical schools have worked for more than 100 years. And in 1912, he made the following statement about high blood pressure associated with atherosclerotic disease. He said, "In this group of cases, it's well to recognize that the extra pressure is a necessity, as purely a mechanical affair as in any great irrigation system with old encrusted mains and weedy channels. Get it out of your heads, if possible, that the high blood pressure is the primary feature, and particularly the feature to treat." So he said, let it happen. And he was very influential. And it probably wasn't the great idea, because for many years, people just accepted that this was the way it is, because he said, get it out of your head to treat it. And everybody listened to Osler. So the fact that he thought it was necessary was one of the reasons it was termed essential hypertension. Essential hypertension means that we don't really know what causes it. It's got an unknown cause. And so what it is now is defined as the upper end of a continuous distribution of blood pressure associated with an increased risk of cardiovascular disease. That's sort of a functional definition. What blood pressure above which what blood pressure, or I should say below which, do you not get accelerated cardiovascular disease or an increased risk of cardiovascular disease? But it's arbitrary, because these things are linear. It's not like there's a cutoff where if your blood pressure is below a certain number, you'll be fine. And as soon as it goes above that, you're not fine. Yet that's sort of how we've always defined it. And that's kind of problematic, because it's a continuous variable. So again, because we had that number of 115/75, where that was the number above which we saw increases in mortality or cardiovascular mortality, it sort of said that there is this continuous variable, and you do worse above a certain blood pressure. And still, there are people who would now look at this blood pressure and say that blood pressure is too low. So again, everything about hypertension is controversial. There's nothing that hasn't been controversial about it. So it's felt that if you measure blood pressure under the resting condition correctly, that if you go above this number, like that paper from the Lancet showed in one of my first slides, that you will do worse. And again, as much people agree with this as disagree with this. So let's just look at the population. Again, if you look at the age groups, you'll see that there's no real gender difference. You're just as likely to get high blood pressure whether you're male or female. But the likelihood goes, or the prevalence goes way up as you increase age. Now, what are the factors that are associated with the increased prevalence of hypertension, at least in America? Well, I think that everybody sort of agrees that sodium plays some sort of a role, and that the higher the sodium intake, all other things being equal, especially if you're sensitive to salt, your blood pressure may go up, and you might do better on a lower sodium diet. We've also started to appreciate over the last few years that from a cardiovascular point of view, eating a low potassium diet is not good for you. If you go back and look at the Paleolithic diet, the diet was very low in sodium because you had to run after things that had sodium in them, and you could just eat the plants that couldn't run very fast back in the day. And if you were eating a lot of vegetables, you were eating a lot of potassium. So since you had to do a lot of running, sweating, losing some salt, and there wasn't a lot of salt around, two things happened. One, the kidneys got very, very good at keeping sodium. They got very, very good at excreting potassium, and that's because the potassium content was very high in the diet, the sodium content was very low, and hypertension was not a big problem back then. I mean, it was saber-toothed tigers, infection, starvation, being hit with a club, falling off a mountain. These were the things that were killing people. Nobody had a heart attack, because you have to live to 40 to have a heart attack, and nobody really did back then, we think. For many, many years, obesity or higher body mass index was associated with a higher risk. It doesn't surprise us to realize that if you have worse access to health care, or if you're using something in excess, substances in excess, you might do worse. Interestingly, though, if you move, if you first live in a non-industrial place, and you move to an industrialized environment, your risk for blood pressure, higher blood pressure goes up just because you've moved. And if you move from the country to the city, it's a risk that your chances for higher blood pressure will go up, sort of indicating that the environment plays a big role. Of course, though, making these moves affects both your diet and your environment. So how many of these things are genetic? How many of these things have to do with your diet? How many of these have to do with the environment? Is still probably a little bit of all of those. And again, it's well appreciated that depending on your genetic makeup and background, certain groups are at higher risk for high blood pressure than others. African Americans and non-black Hispanics have a much higher prevalence and higher risk for hypertension than Caucasians. Here again is the same prevalence with age shown again. It doesn't matter if you're male or female. As you get older, it almost gives you the impression that this is part of living, that this is part of aging. And so I think that there is something to be said about that. The question is how much of this should be limited? How much of this should be accepted? Clearly, we think letting this happen is no longer the thing to do. But let me show you sort of how this might have happened. Right now, if you're sitting in the audience and you're wondering, do you have hypertension? How would you diagnose it? Some people go into the drugstore and they sit down at the free blood pressure thing, and they'll measure their blood pressure, and they'll get numbers that are high. And they'll say, I've got hypertension. But again, you're in the drugstore, people are walking around, you may not be feeling relaxed. It may not be the best place to do it. The best place probably to have your blood pressure measured is probably at home, when you're in your usual environment, and when you have your own blood pressure meter that you know works for you, and where you know your time of the day to take your blood pressure. So clinically, the way we tell people now is the blood pressure that you want to record is the best blood pressure you get during the day, because it can change in the morning or the afternoon or the evening. People sort of figure out when is it good for you to take your blood pressure. I've got hypertension for a few years now. My blood pressure cuff is right next to where I sit when I'm working after dinner, and it's right next to my pills. So the pills and the blood pressure cuff and the work are all together. And it turns out that my blood pressure is very high, but when I start working, it goes down because I'm very relaxed, because I'm thinking about the kidney. So it turns out that one thing good for you is to think about the kidney. But if you really want to know if you have high blood pressure, the way I did it was I got a blood pressure cuff, and for many years it served as an excellent doorstop. Then the box became so damaged from the door hitting it. Turned out that there was a blood pressure cuff under there. So the kid said, what is this thing under the doorstop? I said, oh, it's a blood pressure cuff. So I said, how does it work? And I said, oh, I'll show you. So I put it on, and sure enough, I had hypertension. Well, I had high values. But because I'm a doctor, I said, it's not real. So it can't be real because I'm a nephrologist. And my daughter had already said when she brought me to the emergency room once for a kidney stone how ironic that was. My father is a nephrologist and he has a kidney stone. Isn't that ironic? So I couldn't both have a kidney stone and have hypertension and be a nephrologist. So I thought, well, this has to be wrong. So I looked into the literature and said, well, what would I have to do? I said, well, it turns out that I have to take some measurements, at least 2 measurements, properly measured, my feet on the floor, legs uncrossed, relaxing, at the best time of day for me, and then separate those in time. Maybe I'm having a bad week. But if you could separate those in time and you see consistently, like I did, that every single measurement was high, you have to start to accept the possibility that you might have hypertension. And so I did. And my hypertension was interesting because it wasn't just your normal run-of-the-mill. It was stage 2. My blood pressure was 165 over 105 consistently, And I said, I have to do something. So I went to my doctor, who was a person that we trained here, and said, I got to do something. And he said, yes, you do. You got to make big changes in your life, big changes. And I said, I'll make big changes. And he said, and the first big change you have to make is tell me what you want me to put you on. Okay. So I said, you've been trained well. So I was in stage 2 hypertension, which you're going to see takes immediate therapy. Luckily, I didn't have it for very long, because my blood pressure was 130 over 80 for the longest time at my college physical and all the way through up until a couple years ago. And then I noticed, yes, the prevalence goes up as your age goes up, and it turned out, when I looked into it, my age was going up. So as I've shown you, as I mentioned before, as we looked further and further as time went on, more people became aware that they had high blood pressure, more people were getting treatment for it, and finally, look how bad it was. It used to be only 1 out of 10 had their blood pressure in control, and this is, when Jimmy Carter was president. It wasn't that long ago. But now 50% of the folks have their blood pressure in control. Here's what if you go to the American Heart Association website, here's what you'll see. You'll see this as the color coding that you're considered normal if your systolic is less than 120 and your diastolic is less than 80. This is according to what we call the Joint National Commission 7th report. The 8th report just came out this year, and I'm going to talk about that because that's controversial. So according to the 7th report, this is what you'll see on most websites who are still using JNC7, that there's this middle range here of sort of pre-hypertension, and nobody knows what that means. It's a category. We say it. You can write it in charts. But I don't think anybody really knows what it means because we don't know whether those people should be treated or not. It depends on what else is going on with them individually. But clearly, here was me, 165 over 105. So there was no doubt that I was on the verge of a crisis. And so I didn't want that to happen because the main cause of hypertensive crisis, people used to think it was just, that if you had hypertensive crisis, you must have some sort of secondary cause of high blood pressure. That was very rare. But it turns out the most common cause of hypertensive crisis is people with uncontrolled essential hypertension. So I was in the category at risk for this. And I had taken care of enough people that had this that I didn't want it. So this is what's currently on today's American Heart Association website. And if you go to Wikipedia, you'll see that it's bad to have high blood pressure because it's bad for all of the things where those pressures have areas of organs that are fed by arterioles that control their blood flow. And so the most important organs in the body, like the brain, the heart, and the kidney, control the flow rate of blood to them. And so if you damage with high pressures these arterioles that regulate the flow to these organs, along with the blood vessels, will get damaged. And so what happens is you'll have strokes, other things bad for the brain, the eye, and the heart and blood vessels, and especially the kidney. And we take care. I mean, if you walk into a dialysis unit and you see 100 people on dialysis, 80% of them, 80 of them are there at least because they have high blood pressure contributing to their end-stage kidney disease. Many of them have diabetes as well. So together, diabetes and hypertension, probably 85% of all patients on dialysis. Here's the benefit of treating hypertension. Randomized controlled trials have shown that the risk for heart failure, stroke, and cardiovascular death of some sort goes down significantly when you bring people's blood pressure under control. So if somebody says, is there good reason to control blood pressure, these are the hardest endpoints you have. Death, heart failure, stroke are very hard endpoints. You definitely know when people have had them. And these are the events you want to prevent by controlling blood pressure. These are devastating events. So if you go to WebMD, they're going to tell you to do things that are good for you. The DASH diet, which is a diet that we recommended and continue to recommend in nephrology. It's a higher potassium diet, so if your kidneys are good and you're not having difficulties, a high potassium, lower sodium diet is the recommended diet. They also recommend, of course, diet and exercise are the two classic things, very easy to say, not so necessarily easy to do. But at least they've got quantities now. How much should I exercise? Well, 150 minutes a week seems to be the number that people are talking about. Now, people can keep track of that. And now we have these things that we can wear that tell us how many times we've taken a step. So, if you don't know what kind of a diet to eat, try the DASH diet. If you don't have any exercise program, walk for 150 minutes a week. That's a good way to start. Get a dog and walk. My blood pressure got high, I said, I need a dog. And the dog just looks at me like, well, you poor guy. Here's what the NIH says. The NIH says the same kind of numbers that you saw for the American Heart Association. And the NIH says don't eat more than 2,300 milligrams of sodium. That's a teaspoon of sodium. And that means look at the labels. Try not to eat canned foods and processed foods. Dr. Hood would say shop in the perimeter of the grocery store, not the middle where the cookies are. And that's probably good advice. So if you eat a good diet, if you exercise a little bit, and if you stick around the perimeter of the drugstore, of the grocery store, it's probably the and the drugstore too. It's where the good stuff is. And finally, you want to go to the #1 best hospital in the nation. And it turns out that Mayo Clinic says they're #1. So I'm going to take this same sticker and put it on the Fletcher Allen ones, and then we'll be #1. But Mayo Clinic, the best hospital in the world, is now, you'll see that these are a little bit different than the other two websites I showed you. Mayo Clinic is different because they have already put on their website the JNC8 recommendations. So the difference between the American Heart and NIH, which still have the JNC7, is you're seeing some difference here. So if I go back a little bit, and you see this 120 to 139 would be considered pre-hypertension, and 140 would be considered high blood pressure. Certainly 150 would be. You see now there have been changes, and the changes are that if you're a healthy adult 60 or older, you're just supposed to be at less than 150 over 90. This is a big change, and a lot of people are concerned about this, and I'm going to talk much more about that. And you see their asterisks here. Although 120 over 80 or lower is the ideal blood pressure goal, and that's just, they just say that. We don't know that. It's just, they're just throwing numbers out here. And you'll see there's a lot of throwing out of numbers. And this is very, very, so the latest JNC8 recommendations are very controversial because they think it's going to cause a lot of people to have trouble that didn't used to have trouble. So that's what I want to talk about. This is the most recent and the biggest thing. We've all been waiting for this. We waited so long for this that instead of calling it JNC8, we called it JNC late because they were so, it took such a long time. JNC7 was 2003, and this was 11 years later, and people thought that we should get recommendations every 5 years or so. So this just came out in JAMA, the Journal of the American Medical Association, and it's really gotten people talking about hypertension again, because here, I'll give you the bottom line, the treatment goals are what the Mayo Clinic webpage say. It says if you're under 60, that we should, as a doctor, should not initiate treatment until systolic blood pressure is over 140 and diastolic is over 90. We shouldn't initiate treatment. If you're over or equal to 60, we shouldn't initiate treatment until you're 150 over 90. This is clearly different than what we've said for many years. And if you have special conditions, diabetes or chronic kidney disease, then instead of the 130 over 80 that we were always trying to keep our patients at goal, it's also higher. So now you start to see why people have concerns. And again, to really get a feel for these numbers, I have to show you the history, which is my favorite part of the talk, which hasn't come yet. It's coming now. So these are the things. There's many, many factors that influence blood pressure. I'm going to talk about a couple of these, dietary salt, and I'm going to talk about the kidney. And again, tobacco is bad for the endothelium and for blood vessels. There's a lot of things that you can also say. So you should try not to age. You should try not to be under stress. I don't know what this is about. You got to pick something. But maybe there's some modifiable things. You can't pick your parents, and you can't stop aging. So what can you do? And I want to talk about a couple things that have informed us about at least the pathogenesis of hypertension. One hypothesis is that blood pressure is basically controlled by the kidney. One sort of easy way to remember this is the cornerstone of treatment for high blood pressure has been thiazide diuretics since they came out in the late 50s. It's still the #1 choice. I'm on 2 blood pressure medications that have brought my blood pressure under very good control. One of them is called chlorthalidone, which is a thiazide diuretic. And it really, when I stopped taking my chlorthalidone, because of course I've tried that, I don't really, it came under control, and you say, oh yeah, it's an accident, just true and not related. These drugs aren't really doing anything. So I would go off of them, just to see, and of course, a couple of days off of it, my blood pressure goes right back up. I am convinced, okay? Even though I was teaching it for years, it doesn't apply to me. I teach it, I don't take it. So the fact that the main way these drugs work is to increase the sodium excretion by the kidney tells you something about the fact, and that they're so effective, tells you that the kidney must have something to do with it. Let me show you a little bit about salt ingestion first. This is taken from the New England Journal from a couple years ago, or maybe last year, where it shows how much salt is recommended to be eaten by the general population. These are 2,300 milligrams. How much you're supposed to eat if you're in a high-risk group, that is, if you're African American or you have chronic kidney disease or diabetes, and then what the people do. You see, as we tell people, eat less salt, you see how well they respond. Eat less salt, okay. Eat less salt, okay. And you see this is almost, if anything, it looks like it's going up a little bit. So nobody listens. And I think what you have to do to take care of people is to stop telling people what to do and try to help them do what they're not able to do and understand that as the default. You know, when I take somebody and we do a kidney biopsy on somebody, I'll say to them, okay, we're here today to keep you comfortable and safe, and if we're lucky, we'll get a piece of kidney. In other words, it's not about the procedure. It's about keeping them comfortable and safe. And, you know, we'll cancel the procedure if it's not going to be like that. So, you know, start to listen to people. And if they're having trouble doing something, there's a reason. So it's hard for people not to eat this much salt. It obviously shows in this country. So this is what's bad about eating too much salt. Now, here's a very interesting experiment that we now know from many experiments that have been done this way that shows that the way the kidney handles salt is related to blood pressure. These rats are cousins. They're doll rats. They're cousins. They have a genetic difference, but they're very much related. One of these rats can eat as much salt as he wants, and his blood pressure won't go up. He's called salt resistant. The other rat, his cousin, is very sensitive to eating salt. If you put that rat on a salt diet, the blood pressure goes up, and the more salt, the more the blood pressure goes up. So interesting, several groups have done the experiment where they said, what happens if we just take the kidneys out of this rat, put them in this rat, and vice versa? So it turns out that when you do the transplant, the kidney determines whether the rat is sensitive to salt or not. So something about how the kidney is handling sodium seems to be where the blood pressure goes. So the blood pressure travels with the kidney. And so we at least know that's part of it. I'll show you more data that supports that. This is showing you a diagram of the nephron. And what it shows you is, I have this in here for two reasons. One is to show you that each part of the nephron has figured out a way to reabsorb sodium. The loop of Henle reabsorbs sodium with this protein from the urine. The nephron here reabsorbs sodium with this guy. And the late part of the nephron reabsorbs sodium with a channel for sodium. And so the kidney has, over time, learned how to reabsorb sodium. And the reason for that is because sodium was in short supply, and sodium is what keeps your extracellular volume in shape. And so you will go into shock if you lose too much sodium. So the kidney got very good at keeping sodium. If you were bitten by the saber-toothed tiger and you had to run away but not bleed to death, you would at least want to have sodium being reabsorbed to prevent you from going into shock. Women know this very well. Women who are having menstrual cycles know that they feel bloated every month because their body and their kidney is preparing them for a hemorrhage, because every menstrual cycle ends in a hemorrhage. And so to be able to have enough extracellular fluid to be able to tolerate that hemorrhage without shock, the kidney spends some time reabsorbing extra salt. And the same thing happens when a woman becomes pregnant. They'll get a much bigger extracellular fluid compartment, complain maybe of some swelling and edema, but it's because they're going to have a major event at the end of 9 months, and there's going to be some bleeding, and somewhere in there is a baby. So you have to have, the kidney has to be able to reabsorb sodium if it's in short supply. But the other thing that we now know is there's multiple genetic diseases where the blood pressure is either high or low based on whether the kidney is over-reabsorbing sodium or under-reabsorbing sodium. So every time there's a mutation of one of these proteins, if the mutation causes the kidney to let sodium go, blood pressure goes down. If the mutation makes sodium come into the blood from the urine even more, you hyper-reabsorb sodium, the blood pressure is high. There's no exceptions to this rule. For every disease that we have that's a single gene disease, if that single gene affects the hormone system that talks to the kidney or directly affects a protein in the kidney that transports sodium, whichever direction the transport of sodium goes, the blood pressure goes. If more sodium comes into the body, the blood pressure goes high. If more sodium leaves, the blood pressure goes low. So I want to just show you one great example of this. In 1962, a 16-year-old girl was at school, and she complained of a headache, and she had good reason. She had a blood pressure of 180 over 110. Everything looked pretty normal about her otherwise, but when they measured her blood tests, they noticed a couple abnormalities. It turns out her potassium was a little bit on the low side. And it was interesting that this girl had she was one of 11 brothers and sisters, and when they went and looked at the family, 7 of the 11 kids had tremendously high blood pressures. The younger brother had blood pressure even worse than hers. And when they looked at the family, this was the whole family tree, this was the patient, the 16-year-old. This is all her brothers and sisters. And everywhere you see one of these circles is a patient who had high blood pressure. The other thing you see is she got it from her mother, well, her grandmother. This is her grandmother, gave it to her mother, gave it to her. And what you see here is a bunch of lightning bolts. I put the lightning bolts in, these are people who died before they were 40 of a stroke, okay? And it's because these people all had one little thing wrong with them, just one tiny thing wrong with them. The tiny thing wrong with them was that in that part of that last part of the kidney nephron, which is right here, in this last part, this sodium channel, which takes sodium from the urine and brings it back into the cell and then into the blood, what's wrong with them is this sodium channel. So this is the urine and this is the blood. And normally we all have this channel that lets sodium come in and then go back into the blood. But in this family, this channel was living on this membrane and spending too much of its time being open, letting sodium come back in. It was the only thing wrong with them. Otherwise perfect. Perfect heart, perfect blood vessels, everything perfect. But it showed that if this was going wrong, as the only thing going wrong with you, your blood pressure wasn't just high. It was super high. And it was super high at a super young age. So that showed that all that it takes to have high blood pressure is to hyper-reabsorb sodium. Every patient that has this mutation has high blood pressure at low ages. So are they salt sensitive? Yes, they're very salt sensitive. Now, I take care of all those people with this syndrome in Vermont and New York, both families. So, I mean, there's not a lot of families, but the families have 1 million kids. So whatever this disease is, it doesn't interfere with having a lot of kids because they all have 1 million kids. And they all wonder, you know, what do we do for our kids and not get this high blood pressure? It's very simple to treat that disease. We have a drug, it's an old drug that blocks that channel. So a combination of a low-salt diet and blocking that channel, they're perfect. The only time you have trouble is when the women get pregnant, you have to take them off that medicine because the medicine's bad for the baby. And so that can be challenging getting them through their pregnancy. So to show you something, I just wanted to take a second and just show you that up in Maine, near Bar Harbor, is a place called the Mount Desert Island Biological Laboratory. We take medical students there after the first year of medical school for their last summer to try to do some research. And there's a very famous guy named Homer Smith, who's basically the father of kidney physiology. And he spent a lot of time here in the 1940s to the 1960s, and the room he spent time in is called the kidney shed. Here's the view from the kidney shed. So it's a very nice place to be, and here's how we give lectures out there when the students come out for a week. It's very nice. Here we are in the kidney shed, and what we're doing, I'm going to just show you. We took these microelectrodes, and what you see here is there's a little small circle in there, a small sphere. That's a frog egg. So this frog egg has got 2 microelectrodes stuck into it. And what we've done is we've taken the gene that codes for that channel and injected into the frog egg. The frog egg doesn't know, that it's not its own protein, and it just makes the channel and puts the channel on the membrane. So we took 2 sets of eggs. One set of eggs we injected with the normal protein, the one we all have, and the other eggs we injected with a protein that's got the mutation that this 16-year-old girl had. Okay? And we went to see what happens, what's the difference when you assess the currents, that is the electrical current in the egg that we confer. So what you see here in this plot is if you just look at an egg that's been uninjected or just injected with water, there's no currents to be measured. If, on the other hand, you inject the egg with what we call the normal epithelial sodium channel gene, you get fairly substantial and very nice currents, much bigger than the water-injected egg. But if you inject the egg with the mutation, you get currents so big that the amplifier starts to have trouble controlling the currents because they're so big. So what this says is the mutation, the channel works fine. But what happens is this channel goes out on the membrane of the egg, and instead of doing the usual cycle of being made, put in the membrane, and taken out of the membrane, it's a circular process, this channel goes in the membrane, and because of the mutation, it's forgotten about, and nothing ever pulls it off the membrane. So it stays there, reabsorbing sodium like forever. And that makes these people very hypertensive. So if this egg had a blood pressure, this egg would be very hypertensive. But it's just an egg. So that's the salt story. And it shows you that salt alone can do it. And that's why it makes sense to recommend, at least as a first step, lowering sodium. Now, another thing that we have appreciated more recently is that people who are born with less nephrons in their kidney than other people are at higher risk for hypertension. This is kind of amazing. It also tells you that the kidney is playing a key role. So what's happening here, I'll show you. The New England Journal of Medicine about 10 years ago published a landmark study where in Germany what they did was they did autopsy studies where they took people who had died in an automobile accident and took enough of these patients who had a history of hypertension and those who didn't have a history of hypertension. That's how they controlled. So everybody passed away at a young age from a car accident, and either they had a history of hypertension or they didn't. What they found was that the patients with hypertension, instead of having 1.5 million nephrons in their kidney, in each kidney, had only about 700,000. And that if you looked at the little filtration unit, the glomerulus, which is the little blood vessel that filters, the hypertension had caused the patients who had hypertension to have a very big glomerulus, as opposed to the regular non-hypertensive folks who had a much smaller glomerulus that hadn't been damaged by the high pressures. So this was interesting to people because they said, well, you can donate a whole kidney to somebody and not get high blood pressure. So how is it that this makes sense? Because you give half your nephrons away when you donate a kidney, but you don't get hypertensive. It's all about being born. It's how many nephrons you're born with. That's the key. So people have known for a long time that smaller birth weight babies have a much higher chance of having high blood pressure and kidney disease. So what I show you here is that if you look at birth weight of these people, not these same people, but if you look at birth weight, you can separate birth weight into the low birth weight babies and then the next two levels. The number of glomeruli, that is the number of nephrons in those kidneys, 1 million if you're the normal birth weight, only 780,000 if you're born small. And again, you have a bigger glomerulus volume if you have less nephrons. And again, if you look at the people that had hypertension or no hypertension are the people with more glomeruli, more nephrons, 1 million versus 750,000. And again, that high blood pressure has caused the filter of the kidney to get pathologically bigger. So again, you can't pick your parents, and you can't pick how many nephrons you have. So this goes along very well with a hypothesis proposed in the 80s by a famous nephrologist named Barry Brenner. It's called the Brenner Hypothesis, where he said it's your endowment of nephrons, the number of nephrons you're born within your kidney, that determine whether or not you're going to have a normal blood pressure or not. And that does play a big role. And the less nephrons you're born with, the more work each nephron has to do, the more pressure it might see, the more it has to filter, the more it gets damaged, and you get this vicious cycle. So we don't know how many nephrons we have, but clearly a person who looks salt sensitive may not be anything more than just somebody who's got less nephrons than the next person. So this is very interesting, and there's no easy way right now to look at people other than their kidney size to guess how many nephrons are there. This is all done on pathological specimens where you have the whole kidney. Does it work the other way around? What happens if you give more nephrons to an animal? Well, this is the first study that did that. This was just recent, a couple of years ago, where these folks took animals and put them on 3 different diets: a regular salt diet, a 5% salt diet, an 8% salt diet. And what they found was the regular animals who didn't have a high nephron endowment, the more salt they ate, the more their blood pressure went up. But the animals that had higher numbers of nephrons, their blood pressure was much less sensitive to the salt intake. The more nephrons you have, the less salt sensitive you are. So it works in both directions. And it shows that things were fair because both sets of animals were excreting the same amount of salt every day, meaning they were in steady state and eating the same diet. So this effect wasn't due to that they were just eating less salt. They were really eating the same amount of salt. But these animals were much less sensitive because they had many more nephrons. So this recent data tells us that maybe the kidney is very, very important in the control of blood pressure. We sort of knew that, and that's why if your blood pressure is out of whack, you should come see the kidney doctor. Same slide again. So this brings me to the fun part of the talk, I think, which is where I'm going to hopefully kind of finish up here by showing you some fun stuff. And that is, why do we measure blood pressure? And here's like in class now in medical school, we give medical students clicker questions. They have a clicker where they can put A, B, C, or D in, and then we can get statistics on what they're thinking, and we can figure out where they're having trouble if they're under a misconception. So this would be an example of a clicker question. Why do we measure blood pressure? Well, A says because people with hypertension are at risk for cardiovascular disease. Well, I think that's pretty true. So that's got to be good. Because hypertension is a disease is B, okay, and because we can. And what do you think the answer is here? A, B, C, D, or E? Okay, I heard half the people say D and half the people say E. The D's have it. Because hypertension isn't a disease. I don't think it is. I think hypertension is a number. It's a risk factor. It's something that can lead to disease, like a stroke. But hypertension itself is not a disease, because if it is, then we can say, who wants to say that 1 in 3 adults in our country is diseased because they have hypertension? I'm diseased. I'm riddled with it. You can tell by looking. But a lot of this is because we can. Pressures are easy to measure, but that's not what your body cares about. Your body, so we said, why should we let this happen? This is me coming back to why should we let this happen? Why don't we take people that are young in their 20s and say, this is your blood pressure. And here's a bunch of different things you can do to keep your blood pressure staying there. You can eat less salt. You can exercise more. You could not smoke. And if you need medications, there are plenty of medications now that we have. So would it be smart to keep blood pressure at a constant? So for years and years since I've had cats and dogs, I've always put the cats and dogs, so they always die of kidney disease. I put the cats and dogs on a little bit of an ACE inhibitor, which is an antihypertensive. And they just never die. These animals just never die, okay? And so apparently it helps them not get their kidney disease. Now this isn't a controlled study, it's just my animals. But when ACE inhibitors came out in the late 80s, I was an intern. And I said, are you kidding me? You got something that you take that relaxes your blood vessels, reduces the afterload on the heart. So when the heart pumps, if the pipes are wider, the heart has an easier time. And the blood pressure is lower. I said, I got to have some of this. It was called Squib 1655 at the time. I started taking it because I said, this has got to be good. This got to be good for you. But you're not allowed to take it without a prescription, I found out. So I had to stop taking it. But I really wanted to take it because I thought this would keep me going for a long time, even if it ever happened that I was going to lose my hair. And if you look hard under the lights, I am getting a little spot up there. Okay. But the question is, should we control this and not let this happen? And that's where the medical students all know that I always talk about flow. Because the body doesn't like I mentioned before, the body, no system in its biological system likes to be at a high pressure. It enjoys high flows. High flows at low pressures. That's what kids have. So kids have high flows at low blood pressure. You don't worry about your kid having hypertension. You don't even take their blood pressure until they're in their teens. So the idea is that since it's the total peripheral resistance, that is the constriction of arterioles that determine your blood pressure, if you have blood vessels that are more open, the flow would be to the organ better. So my theory is that your brain does not know what your blood pressure is. I don't believe my brain knows what my blood pressure is. I think my brain knows what its blood flow is because it controls that. And that's what I'm going to show you on the next slide. What's called autoregulation of flow is the difference between having an arteriole and a piece of ZD. If you increase the pressure in a piece of ZD, it will expand. If you decrease the pressure, it will contract. But the arteriole does the exact opposite. When this is a graph that shows blood pressure versus flow. This happens to be flow to the kidney, but it doesn't matter. This works for brain, heart, and kidney. This is where you want your blood pressure to be, a mean arterial blood pressure of about 83, 85. Okay? If the blood pressure is here, it's high enough to be above this shoulder. And then additional blood pressure doesn't get you anything with respect to flow. Flow is clamped. So the organ, the brain, the heart, the kidney, is trying to maintain a constant flow. And what this slide says is as the blood pressure goes up, to keep the flow constant, the arteriole has to constrict against it. That's exactly what you don't want. So you don't get anything. The brain gets no more flow, but your blood pressure will go up. And it will continue to go up, and those blood vessels will get damaged, because the only thing you get from being more to the right here is barotrauma, endothelial damage, and I think probably you set yourself up for more and more of a positive cycle of your blood pressure getting worse. So it's best to live here. And that's the reason, I brought the kids up on a low-salt diet. They have no taste for salt. They just don't like it. For them to eat a Dorito is like biting into a lemon. It's very unpleasant for them. And that's good, because they have no salt appetite, and they pretty much live here. So like the dogs and the cats, the plan is for the kids to live forever. Okay? And I have no chance, because I've been raised on McDonald's French fries, and I got to have them, and they're salty, and they're bad for you. And I'm not going to live there without medicine. With medicine, I can live here, but not without. And all I was getting was nothing for this except damage. So it shows that since the main vascular beds of your body are always concerned with just regulating constant flow, because that's how they get their oxygen, the nutrients, pressure doesn't get you anything. What we should be measuring is pressure, is flow. That's too hard to measure. So we measure pressure as a surrogate. But that's not the physiologically most relevant parameter. So flow is again, you'll understand this in your regular life. We always pay for this. It's flow that you pay for. If you go away on a trip, your house stays at 120 volts, but you don't draw any current, so your bill is going to be very low. It's only the current that you use that you get billed for. If you travel by car, train, plane, or boat, it's only when you get somewhere. Disease examples are we all pay to treat constipation. We all pay to treat that. Asthmatics pay for the good airflow in their airways by paying for their medications and getting back that flow. Patients with heart disease pay for reestablishing their coronary arteries by either a bypass or an angioplasty. Pay a lot for that. And older men seem to be paying a lot of money for things that increase the flow of urine and blood in the pelvis. As you get older, urine outflow stays the same, but your ability to have the stream come out the way it was when you were young goes away. You pay money to take medicines that give you back that. One of them is called the Flomax. That's my favorite name of a drug ever, because that's it. Okay, so in the last few minutes, I just want to show you how I think it sort of began and where pressure came from. So when it all began, there was a lot of sodium in the ocean. And then somewhere, either in the ocean or kind of near the ocean, life started in what was called the potassium solution. And life still is in a potassium solution. And there had to be a membrane that had to develop to keep the potassium and the sodium on each side. And then to make the potassium stay in and the sodium stay out, you needed to have a pump. So the cell looked like this. There was this pump that uses energy that pumps sodium out and potassium in. If you look at this hard enough, if you're a kidney doctor, you will look at this and you'll realize that this pump right here, which was one of the very first proteins that had to be invented for life to continue, this was itself the first mouth, the first gut, and the first kidney. The cell was eating potassium and excreting sodium. And the cell would just sort of move along in the solution, excrete sodium, and just sort of pretend nothing happened. And so these cells are getting rid of their waste product, which for them was sodium. So they needed the sodium on the outside, but they needed it to stay there. So they pumped a lot of sodium out and potassium in, and we still do that. So there didn't need to be any circulating solution, because diffusion could bring everything to this cell. When organisms became much more complicated, they couldn't meet their metabolic needs by just having things diffuse around them. So as they became bigger, you needed to have a circulatory system. And in the first circulatory system, the hearts didn't know how to really beat yet. So the body movements of the thing swimming sort of moved the solutions around. So the first circulatory system was just, sort of swim. And then finally, a 2-chamber pump, the first heart developed, and then a 4-chamber heart developed to make this more complicated, because you had your toes are going to be far away from your heart now. So a long time ago, I gave a talk that, how do you enjoy good flows without bad pressures? And should hypertension be essential? And of course, the answer was no. If you look at this this is a picture taken from Homer Smith's book from 1951. And he hypothesizes that early life was an animal that looked like this, the predecessor for us, something that had a backbone. And it was segmented. And what you see in this animal, which, by the way, apologies, any resemblance to amphiosis is purely coincidental. Okay, just saying. So what you see here is, what do you see? You see an organism with a tiny, tiny brain like no brain at all. A big mouth that's got something on it to be able to really get a lot of area of what's going on. And it's supposed to swim forward. And it's just like in Finding Nemo where Ellen DeGeneres goes, just keep swimming, just keep swimming. Just keep swimming forward, keep your mouth open, and anything can come in. And the two most important things is every segment has two holes on it, a big hole and a small hole. Every segment has a big hole and a small hole. The big hole is the gonads, because that is the reproductive system, and that's going to keep life going. You don't need any brain for that, okay? Just keep letting the reproductive stuff get out and get fertilized. And then there was this one other thing. The other little hole was the tubule of the kidney, of the original kidney. It says, we let anything come in, but we'll regulate what stays in and what goes out. And every segment knew how to do that. And if you sort of use your imagination, this had to be eventually taken off the surface because all these things, it had to become waterproof because when this little organism went from salt water to fresh water, it was necessary to pump all that water out. And guess what got invented? The heart to do it. So what happened is the marine animals developed this waterproof covering, but that wasn't enough. You needed to take these holes off the surface. And if you can imagine, if you have an animal like this, and you were to say, if we had to pull all these things down, what would it look like? Well, you'd pull them all down and back. You put them in the back here, protected. And if you take these all and pull them back, you sort of get something that's kind of kidney-shaped. And the other thing you notice is anytime you open something up and you look at the kidneys, right on top of the urinary tract, always, is the reproductive system. In some animals, they're the same. They're right on top of it. And so the reproductive system and the urinary tract have evolved together. They're always together, okay? And that's why, I think that's why. So to get rid of all the water, the heart had to act as a water pump, and the kidney had to be the place where all this water was going to get pumped out. So what happened was there was this prenuptial agreement between the heart and the kidney, and what the kidney said, the heart said, well, we need in to the kidney. And the kidney said, look, we're just a tube, we don't need any blood. And the heart said, well, I've got something fancy for you. And they built this, the world's best capillary is the glomerulus. It's the fanciest capillary ever. And the kidney was pretty impressed. He said, oh, that's not bad. That's not bad, heart. So the kidney says, you can come in, we'll make room for you. And it was Bowman's capsule opened up and the glomerulus came in and it was like really nice for a while. But it turned out to be a disaster because trusting the cardiovascular system was a disaster because the heart tried to pump everything out and the kidney had to start reabsorbing everything back. So if you can imagine, the kidney works in the following way, analogy to your house. If you want it to clean, let's say there's one tiny little spot of dust on one table and you want to clean that. You would normally go over there and clean that dust, okay? Unless you're me, it just confused. But the way the kidney would do it is this. The kidney would take all of your furniture in your house, put it out on the front lawn, okay? All of it on the front lawn. It would then clean that little tiny part and bring everything back in again. And that's exactly how the kidney does it. And it's a genius. It sounds stupid, but the kidney really knows what it's doing because it couples everything to that process. So it turned out that, again, the kidney is like us who look at the thing. The big problem is an opportunity. And so the problem was you're trying to kill us. That's what the heart's always trying to do. Stroke, heart attack, kidney failure. It's always the cardiovascular system trying to kill you. The kidney puts a brake on that, and the kidney used this as an opportunity to do a lot of different things, which basically is the course we teach. But this worked out in the end, but it was a bad idea at first. But it was necessary. That high pressure that we now have to deal with was necessary because you needed high pressure for the nutrients to get everywhere and originally for that water to be pumped out of the system. So, it's interesting. The heart works hard at one end to pump a huge amount of water out, and the kidney tubes work hard at the other end to defeat that, keeping 99% of the stuff the heart tries to pump out. But this is common. Nature frequently does this, and you can see everything that we're interested in, a lot of things that we're interested in is pitting these two forces together. So if you saw like, I forget the name of the movie, but there was this movie where Darth Vader is bad, and he's got some son named Luke, but Luke doesn't know that's his dad until the end, and they fight each other all the time. It's like your dad and good versus evil. And then there was this other book, I can't remember exactly what it was called, but it's a Harry Potter guy is fighting with this Dark Lord guy. And Dark Lord really evil, and Harry Potter's really good. and they're always fighting. And people will read like 7 books and go to 20 movies just to see how it turns out, because they love the good versus evil. Well, this is it. This is the heart versus the kidney. One of them is very bad, and one of them is very good. And so, but the interesting thing is our lives depend on having them just live in this balance and not really have one of them win. So, you know, we come back to blood pressure. For a long time, it wasn't really discovered. And then in 1896, this guy came up with this term, which is an old term, hyperpaesis, which I thought meant something different when I first read it. I thought it meant eating a lot of pie. But it turns out that it means high blood pressure without a cause, essential hypertension. And Osler, at about the same time in 1916, here's a textbook that I have of his from 1916, he said, the blood pressure varies greatly in different individuals. And he said even back then, now 100 years ago, that it's about, the systolic should be about 120 to 130. And in persons over 50, it could be 140 to 160. This is exactly what JNC8 has now come up with, okay? Okay? And he said high tension is met with bad disease of the heart and the kidney. And, you know, so he refers back to Albert's hyperpaesis. And he also said, you know, that high blood pressure is seen in the following things. He goes, syphilis, which of course the most important single cause of high blood pressure back then. Now it's not a big cause. But the thing was, many doctors said it's because the people are overeating and the stress and strain of modern life. So modern life in 1916, there are men in the 5th decade who have not had syphilis. Apparently this was something to be proud of. I'm over, okay. So it turns out there are men in their 5th decade who have not had syphilis, and they eat and drink with discretion, but they have a very high pressure life. So this whole idea that you should have they told people to retire and relax. And he described TIAs, the transient ischemic attacks. He said if your blood pressure gets too high, you'll have these episodes, these spells, brief, less than 1 day spells of not being able to move certain part of your body, and that is TIAs. And the risk, he was saying that these people are going to go on and have a stroke. Recurrence is the rule. So he was lining out some things here. Then this guy in 1937 said, a raised blood pressure, this is my kind of guy, a raised blood pressure, like a raised body temperature, is merely a symptom. Right, it's not a disease, it's just a symptom. And you should probably try to have it go back where it should be, like the temperature. And what they knew about essential hypertension in 1937, our conclusions are thus essentially negative. We at present completely are in the dark as to the cause of this common and disastrous disease. And in 2014, he could write this exact same thing. We still have no idea what causes essential hypertension. Now, this was the time in the 30s, and people said the greatest danger to a man with high blood pressure lies in its discovery, because then some fool is going to try to reduce it. So the whole point was keep that blood pressure high. It's essential. It's essential. And Paul Dudley White wrote this in his 1937 famous textbook. Don't tamper with it. Okay, here's what happens when you don't tamper with it. This is a president named Franklin Delano Roosevelt. This is his blood pressure from 1935 until he died in 1945. His doctors let this happen because it was essential, and he's having a high pressure life, so we should let this happen. So on April 12, 1945, FDR said his last words, I have a terrific headache. And then he lost consciousness, and his blood pressure was the meter only went to 300, and it was like trying to go beyond 300, and it killed him right away. And so in 1945, hypertension was still not considered a disease of clinical consequence. And again, people let the blood pressure go up. And when they tried to embalm him, the machine broke. I mean, apparently the machine that pumps into the embalming fluid into the blood vessels broke. And so Paul White's textbook said, the treatment of hypertension itself is difficult and almost hopeless with what we know. And in fact, for all we know, the hypertension may be important, should not be tampered with, even were it certain we could control it. We certainly don't agree with that. And so going back to Homer Smith, he basically did understand hypertension and basically sort of guessed and said it's arbitrary, but it's like 140 over 90. Again, 1950, saying exactly the same thing as JNC8 is saying. But it's still in the 50s, it was all a psychiatric disease. The psychiatrist has reported from investigation of a few hypertensive individuals, such persons tend to display exaggerated dependent strivings submissiveness coupled with stubbornness, feelings of weakness and defenselessness, and suppression of hostility, fear of injury, and emotional detachment that may lead to acute emotional disorders. That essential hypertension is the somatic manifestation of a psychoneurologic condition based on excessive and inhibited hostile impulses, okay? And that protracted resentment is the leading motif running through the anxiety, insecurity of the emotional pattern. So when I discovered I was hypertensive at 160 over 105, obviously, I knew it was because of my submissiveness coupled with my stubborn. I mean, I had wondered about that, but now I was sure. So again, this is not that long ago that people thought this. So here was JNC1. This was 1977, and they basically said all adults, you got to treat people who have very high blood pressure, and that if based on age, you could sort of hone in on these kind of blood pressures and check things out. You'll keep the patient under monitor. This is not far away from JNC8. So in JNC1, we didn't have great drugs. But the first drug that you would try would be a thiazide. And then there'd be the drugs that would cause significant side effects. Reabsorption caused depression. There were many people that may have committed suicide because of reabsorption. And I think it could also cause, if I'm remembering right, it could also cause breast cancer. But anyway, they were not great drugs, and they had a lot of side effects. JNC7 was the first thing for the 21st century, and this is what the American Heart Association has. And here's JNC8. The same thing I showed you at the beginning, that now things have moved up just exactly where Osler and the other guys in the 1930s said blood pressure ought to be. So we've come almost nowhere. And this, which I have in your handout, is the way the JNC8 is saying to approach blood pressure. What you see here is first make sure that people really have high blood pressure, separate them into diabetes and kidney disease or not, separate them by age, separate them by race, and then pick certain drugs. So, I mean, this is just a flow chart that are supposed to be our guidelines now. If you look at me on the same chart, initiate a thiazide-type diuretic would be right for me, and an ACE inhibitor, and I'm on lisinopril and chlorthalidone. So this should work for me, and it does. Here are, just to give you an idea of different societies and where they think blood pressure ought to be, you see that they're all in the same kind of range, but there's no general agreement. And they all have different favorite drugs that they want to start, but you see ACE inhibitors and angiotensin receptor blockers are popular along with the thiazides. Here's a strategy for how to start people on medications. Again, I put it in your packet just in case you're interested to read. If you're really interested to read, I'll send you the PowerPoint presentation because it's probably easier to see on PowerPoint. So again, as I mentioned, this was me, and now I'm back to my college days. I'm playing football again. And again, I've indicated to you that the 2014 guidelines are controversial. There's very big concern that this raise to 150 over 90 in patients older than 60 is going to make a lot of people have complications like strokes. So there's very big concern about this. And this was just in this month's, the Journal of the American Society of Nephrology, just this month, is just come out. And what they say is they summarize all the different societies. I think I put this in your handout as well. Different societies in Europe, in Canada, the Diabetes Association, on what the target should be. There's no generalized agreement, and there's a lot of fighting. These people love to fight. I mean, they really do love to fight. So I think this is really kind of back to the future that we've got here. We've got here in 1929, the question of high blood pressure today is such a commonplace clinical entity among laymen that patients ask about their blood pressure as they do the condition of their heart and lungs. It's obviously that as medical men, apparently there were no women doctors, it's obvious that as medical men, we should know more about the condition other than that the pressure is too high or too low. Guess what I know about my patients? That their blood pressure is too high or too low. So in 1929, he said we should know more than that. And I can't say I know much more than that. And his conclusions were, you should keep track of people's blood pressure. And you should, and if you don't pay attention to it, it's going to affect other organs and damage them. I'm going to finish by showing you some things from George Pickering, who was a very famous guy, wrote nice books. He's a stern guy. I mean, this is his best picture. I mean, this is what when they said smile, this is the best he could do. This guy was not in a good mood ever. And you can see in papers he would like attack other people. And it seems quite extraordinary that I have to emphasize this. I mean, it's like, you're really bothering me. The current practice of treating hypertension as a quality is responsible for a whole series of artifacts. Raised arterial pressure seems to have in man a series of consequences that are related to the quantity. Okay, so pay attention to that, he was saying. And he showed, that if you took people who were hypertensive and their first-degree relatives, and you compared them to people who were normotensive, that the people who were relatives of hypertensive people had higher systolic and diastolic pressures than their normotensive counterparts. So he said there is no agreement as to what the dividing line between so-called normotension and so-called hypertension should be. And he wasn't a big fan of the World Health Organization or like the JNC. The great propagator of science by committee has made a recommendation. He thinks it's completely arbitrary, chosen not on fact but by a whim. And we're still in the same predicament today. He says the various complications like heart attack and stroke are quantitatively related to the pressure. Appreciate that it's not just one dividing line. It goes up as a continuous variable. So he says if you don't accept that it's a quantitative one, you're missing the boat. They gave a dinner for him, and he was giving a dinner speech. And so to introduce his dinner speech, this guy decided to write a poem. This is in 1978 in New York. This guy wrote a poem about what it was like to have hypertension, to treat or not to treat. That is the question. And what he said, these were the days of drugs that have a lot of effects, bad effects. The strokes and the heart attacks. But then, if you live, and there's the rub, for in the living and loving, what fate may come when we take our pills must give us pause. There's the impotence that makes the calamity of a long life. So, I mean, these are not easy drugs to take. So, I'll give you this poem if you want it. It's funny. And what Pickering showed was even funnier. The guy is quite a guy. He took one of his 31-year-old residents, a doctor, who agreed to wear a brachial artery pressure transducer for a whole day. Okay, and so at this time of the day, between 14 and 16, 2 o'clock to 4 o'clock, Pickering is lecturing he's sitting in a lecture, listening to Pickering lecture, and Pickering says his blood pressure went down because he was probably falling asleep in my lecture. Then, I don't know how they worked this out, but Pickering arranged at 1600 for a nurse to stick the resident in the butt with a needle. And when she stuck him in the butt, his blood pressure went really high. Then the poor guy goes home, and between the hours of 23 and 24, he's intimate with his wife, and the blood pressure is high again, and right afterwards he's sleeping. And here's his blood pressure when he's sleeping. It's very low, actually. And this is known as dipping. So if you have a 24-hour blood pressure measurement, if you lose your ability to dip, that is, if you go to sleep at night and your blood pressure doesn't dip, you're called a non-dipper. It's very scientific. It's normal to dip. If you don't dip, you're at higher risk of all sorts of things. So for ambulatory blood pressure measurements, this resident at 31 was a dipper and had low blood pressure. This is 60 over 40. I mean, this is a low blood pressure. So he's a healthy guy. He doesn't need high pressures. He's got good flow at low pressures. Here at our place, we have the Blood Pressure to Gold project. This was an idea of Dr. Virginia Hood, who works with Sula Point in our clinic. Dr. Hood, you may remember from several years ago when she introduced me. It seems like years ago for you guys. Is this basically what Dr. Hood is somebody who's smart, very, very smart. She knows how people are, and she knows what people can do. So she, instead of making people crazy, she says, look, here's our sheets, here's a blood pressure machine. Go home and measure your blood pressure at the best time of day, figure out when that is. If your blood pressure is 139 or lower, put a check mark in the green column. If it's 140 or higher, put a check mark in the pink column. If there's more checks in the green than the pink, you're doing okay. If you're not there, call us. Beautiful. I mean, it's beautiful. It's a very simple thing for patients to understand. The green is good, pink is high, call us, and the two things to do. This is, really, and this has had a tremendous impact on our clinic. Every one of us treats our patients with hypertension by sending them home with this, and they can email it, they can fax it. they can mail it, they can bring it in with their appointment. And this was a very good, and this is saving lives, saving strokes, saving heart attacks, saving lives. So is hypertension a disease? I don't think it is. I think it's a risk factor for disease. Again, if high blood pressure hurts your endothelium, you're not going to make nitric oxide, which lets your blood vessels relax. It's got something to do with the kidney and how it handles salt. And we have to fight the fact that when we were growing up as a species, in the old days, we needed a sympathetic nervous system, and we needed a renin-angiotensin-aldosterone system to be able to deal with the risks of daily life. Now, we don't have those problems anymore, and we have to block these systems to stay alive. It's not just coincidence that every drug that's been shown to increase cardiovascular survival does so by interfering with the sympathetic nervous system, your beta blockers, or the renin-angiotensin-aldosterone system, ACE inhibitors and ARBs. They prolong survival because they interfere with the same things that used to prolong survival being shut off. Okay? So this is our difficulty is we can't agree on anything, and it wasn't until well after FDR died that we started giving up the fact that blood pressure needed to be high essentially. And now we're just figuring out how to inhibit these same systems that was originally designed very well for the prehistoric hunter-gatherers who had low sodium diet, high potassium diet. So what are the recommendations? Well, yeah, so what was good for our ancestors 50,000 years ago is now maladaptive for us because we can find salt everywhere. What's the take-home message? To have a healthy lifestyle, eat less sodium, eat more potassium. The DASH diet is not a bad place to start. Exercise 150 minutes a week. And right now, we're still working it out whether we're going to go with JN7 or JNC8 for the guidelines, but these are just guidelines. I think it's very important for every patient with hypertension to work individually with their doctor. The great thing, we take care of a lot of people with hypertension. I take care of myself with hypertension. We all do it a little bit differently. I tried to do this study of what would happen if I kept on the same sodium diet. And for me, I'm not that salt sensitive, believe it or not. That's why my hypertension crept up on me. My salt in my diet was constant, and all of a sudden my blood pressure went up, responded well to medications. Didn't make much of a difference when I cut salt out of my diet. So if I would have done that and been uncomfortable on a low salt diet, it would have been for nothing. So that's why every individual is different. And the thing I think, when people say, how do you treat your patients? I say, by sitting down and chatting and saying, what's life like for you? What are you hoping for? What's reasonable? That's it. So when in doubt, try for the 130s over 70s in people with diabetes or chronic kidney disease. And I think this is a picture, again, from Bar Harbor, where we did some of that work. And I'm happy to answer any questions. Thank you. Thank you. Thank you. Sure.
You referenced diet, non-smoking, but no commentary relative to alcohol.
Alcohol? Yeah, alcohol. Yeah, I mean, I think, it was clearly shown in the late 80s and early 90s that a moderate amount of alcohol, especially in the form of red wine, was actually beneficial for the cardiovascular system. So a little bit of alcohol. Europeans drink alcohol with breakfast, and the kids start early. They don't eat a lot of processed food, and they do a lot of walking. And so I think in moderate amount, I mean, again, if you have a little bit of alcohol, it's not bad. But I think if you're overweight and drinking a lot of alcohol, it probably goes along with your other nutrition. So there could be association between somebody who drinks a lot of alcohol and someone who's not eating a great diet. But alcohol itself, as long as it's used like an ounce a day, 1 shot a day, you can go to the NIH website and they'll tell you the definition of a heavy drinker. It's a lot lower than you might think. The difference between what's moderate alcohol and what's a heavy drinker is small. So an ounce of alcohol, where they say like a drink a day, which is 1 shot or 1 beer or 1 glass of wine, is supposed to be not bad. Not bad. Yeah?
If folks who have maintained normal blood pressure throughout their life have associated that with reduced salt intake, as they age, their blood pressure still remain low. Now with the new information that's been released, it's considered perhaps too low.
Right.
Would you advocate them increasing their salt?
Right, I think that's a great question. When you look at the population, you always see for these things what we call the J-shaped curve. And the J-shaped curve is exactly that for a population. It sometimes looks like if you eat too little salt, it's bad for you. But nobody separates out the people eating too little salt and on a good, otherwise good diet, and people who are eating too little salt because they're eating too little, period. So that they're malnourished. So I take these population studies, with a bag of saline because I think that that's where the individuality comes down. I think that it's good if you're talking about epidemiology. When it comes to the individual patient, you want to see and assess their own salt. I wouldn't advocate fixing anything that isn't broken. So with the individual patient, I would say, don't look at the population data, let's look at you. And then we could go from there. But I wouldn't restrict somebody until I could show them that they were doing something that reducing it would benefit them, not benefit the population in general. And we can't apply those J-shaped curves to the individual patient. I mean, apparently the economy is getting better, but that doesn't mean you're not going to find somebody who's complaining about it. Yes? Ooh, a lot of questions.
About an adult who's taking medication for congestive heart failure.
Yeah.
And that medication, the person has like blood pressure in 70,
Yeah.
high 80, but the medication like lisinopril is lowering the blood pressure.
Yeah, so you're saying what happens if you're on a medication for some other process like heart failure, and taking the medication for the heart failure to get rid of whatever is making your blood pressure too low. Heart failure is, means that the thing that generates the pressure is the heart. So of course, if the heart's not working well, you're going to see lower pressures. Usually we run into this problem if somebody needs furosemide, Lasix, to take fluid off. And then, we have to be very careful when we have people on both ACE inhibitors or ARBs and diuretics. You've got to be very careful. You have to tell those people, we have to the best thing is to find out where their blood pressure should be. So I'll take my patients off of, if they need, you make the priority. If the priority is to not have fluid in your lungs, which is the priority, then you need to be on the medications that help you not have fluid in your lungs. And we will dispense with the lisinopril and the ACE inhibitor because that's not the limiting factor for that person. So again, that's management in the office, that's complex, and that's where you really have to see the whole history and talk to the patient. Yeah, but it's a very good point. So we run into the same problem with people with kidney disease. We want to put them on lisinopril, but their potassium is going to skyrocket. And so what do? We tell them, this is an important drug for you to be on, let's change your diet. And that's how we approach it. Yes?
Because you mentioned the connection between the kidney and the heart, what role does water consumption?
Okay, I love that question. In general, none. Okay, what most people do is they drink way too much water. Now, luckily, you have the kidneys that can excrete all that water. I have patients who come in and say, Doc, what am I going to do? I'm up all night peeing. And I said, why? I said, are you drinking a lot of water? Oh, yeah. Oh, yeah. I go, why are you drinking a lot of water? Oh, they say it's good for you. I say, well, I'll tell you this about water. The more you drink, the more you pee. Okay? So I tell my patients one simple thing, and I think everybody could go by the same thing. Drink when you're thirsty. Don't drink when you're not. There's no health benefit to drinking more water. Homer Smith showed that in 1937 when he put a catheter in his urinary bladder, and he quantitated on himself how fast he would excrete water if he drank water and salt if he drank saline. And all of it was gone in his bladder within 2 hours. So if it's going to make you beautiful, it better work fast. So I usually say, I just drank water, look at me. No, I mean, you should drink when you're thirsty. In fact, with the medicines we have people on now, they're at more risk of interfering with water excretion at the kidney. So I think that as you get older and older, your ability to get rid of water goes down. I think you should, if you're not thirsty, you shouldn't drink extra water. No benefit.
I'm just wondering about the person who's on no medications has a really low blood pressure.
So women, let's say, so these are like kids and women in college who are runners. They have if they were to show up in the emergency room, they'd be swept up to the ICU for hypotension, and there's nothing wrong with them. If you don't have a complaint, and your blood pressure is whatever, it's low, it's considered, quote, low, don't fix it. That's just you. You're going to live forever, I think, because that's great to be. That's young college women, yeah.
A couple of words about saturated fat in the diet and the deposits in the arteries.
Well, clearly, I think that people, I mean, it's been well shown that, of course, the high-fat diets and things like that, all of those things reduce anything that builds up in your arteries, fat or anything else, is going to reduce the ability of your endothelium give you little puffs of nitric oxide in a way we can never do. I mean, the reason Viagra is such a popular medication is it gives increased nitric oxide, essentially, to certain parts of the body. But that never replicates what normally happens physiologically. So anything that's going to interfere with the suppleness and the physiology of the endothelium is going to be bad for cardiovascular disease. And that's why it's now appreciated that men who have the complaint of any kind of erectile dysfunction, that is the sign of peripheral vascular disease. That is the sign of cardiovascular disease. And we take that very seriously now because that's a symptom that somebody says, well, you know what? That tells us you're in some cardiovascular trouble right now. So we would treat them aggressively. But you should check with your doctor before sexual activity.
What about a potassium supplement? I mean,
Yeah.
I feel in our daily diets we're getting enough potassium?
Yeah, I mean, potassium is in everything that tastes good. So, I mean, when our dialysis patients are on a very low potassium, we try to put them on a low potassium diet. That's not fun, really. In our clinic, we have a picture menu of the foods that are high in potassium and low in potassium. We find that it's much easier for people to look at pictures than to look at a long list. And so these are available. We can send them out and make it available to help people, because we think potassium shouldn't be supplemented in a pill form. Potassium should be taken in the diet. So, for example, a banana, every inch of banana that's standard banana diameter, SBD, has 1 milli equivalent or millimole of potassium in it. So instead of me putting somebody on a 10 millimole a day supplement, I just say have a banana. It's much better to get your potassium that way. So you should supplement it in your diet, but not with pills unless there's a reason to. Yeah, yeah.
Can you have high cholesterol and not high blood pressure?
Yes, of course you can. I think the way we look at these risk factors is when we're trying to figure out somebody's cardiovascular risk factors, we look at the big 6 or 5. You know, do you have a family history of cardiovascular disease? There's nothing you can do about that, but we want to know. Do you have diabetes? Do you smoke? Do you have high blood pressure? Do you have high cholesterol? And for men, do you have gout and maybe a sedentary lifestyle? So what we do is we're in the business of risk reduction. So we would take all of the risk factors that somebody has, and we'd say, if there's just one alone, like I think if somebody has nothing on any of those and just a high cholesterol, I don't think they're at very much increased risk. It's because those people also smoke and have high blood pressure and have a family history that causes their heart attack at 55 years old. So that's why, yeah. So one last thing. So if somebody said, I only have this, should I take a statin? Which may not be the world's best medication for other reasons. I would say no. But again, I'm no expert. I'm not even graduated from community medical school yet. Go ahead.
So, are the effects of hypertension cumulative? Let's say you have hypertension, you know you don't take any medication.
Yeah.
And then all of a sudden you start taking medication. Are you still damaged from the cognitive?
Yes and no. There is a way. So certainly we can look in a person's eye grounds at their fundus, at their retina, and if they have hypertensive retinopathy, that won't go away. That means that they've had long-standing high blood pressure. That won't go away. If they've had kidney disease from their hypertension, that may go away a little bit because when blood pressure gets controlled. But if there's already been damage to places that only know how to form scar tissue, like the kidney, the tubules know how to get better, but the blood vessel part doesn't. So if you've got scar in your brain, scar in your heart, scar in your eye, scar in your kidney, that's not going to get better. That being said, what we're always trying to do is slow things down. So again, it's never too late to do all these things. And then there is always that person, there's always somebody who says, oh, my father smoked like a chimney and he's still alive at 115 years old. And they say, how do you explain that? I say, he forged his birth certificate. But the thing is that it's never too late. I mean, every morning when I get up and look in the mirror, that's the thing that keeps me going. It's never too late. I could still become tall and good looking. Yeah.
So I'm a little unclear about this latest study.
Yes.
We're going to hire is considered normal, or are they just saying you shouldn't take medication?
Yeah, I think what they're saying is if you meet somebody who's 67 years old, and if you would have met them a couple years ago, and you would have been looking at JNC7, you would have thought about treating them at a blood pressure of 148 over 88 or 92. Now you would say, you know what, I'm maybe going to be a little bit more conservative with you. Now the reason for that is that JNC8 was put together by looking only at randomized clinical trials. That meant that when they looked at all the studies, they eliminated 98.1% of the studies because only less than 2% were randomized clinical trials that they drew data from. And a lot of this is just expert opinion of people who know a lot about high blood pressure. Again, it's an individual thing. I would have to look at that patient. I want to look in their eyes. So if I saw somebody who had a blood pressure that was, these are guidelines, but if I looked in your eyes and I saw evidence of blood pressure damage to your retina, then I would treat you. And I would say, the reason I'm treating you is because you have evidence of target organ damage. And so the guideline will tell you one thing, but that's what we have to stress. These are just guidelines. It gives you an idea, gets you in the ballpark. But everything else is all about the individual, and everything else is all about what do I see when I look in your eyes. So I can imagine two patients who are exactly the same, age and blood pressure. One I look in their eyes and I see something, and the other one doesn't have it. I could imagine having differentiating treatment for them based on that.
I'm sorry, just one more.
Yeah.
How can the numbers change when the correlation apparently based in fact with bad outcomes? Because there's some information that says when we've treated older folks with medications for pressures that were not severely elevated, that we might have caused more of them to have falls. So somebody falls and breaks a hip. All of a sudden you've gone from not a big risk of dying to a big risk of dying because you've broken a hip. Okay? So I think what's happened is that there's a lot of people who come, you spend a little time in the emergency room, and see how many people come in every day saying, I fell. I ask every one of my patients now, have you fallen at home lately? They say, what's that have to do with the kidney? They say. And I said, I'm just nosy. The reason is because their kidneys aren't going to continue to come to see me if they fall down and die. So knowing, again, these are the kind of things that we're seeing some unexpected things. So I think the thought is that by, quote, maybe over-treating people, I don't know if we call it that now, is caused them to fall or have other side effects that have gotten them sick. And I think they're experimenting with that. But clearly, since we haven't come anywhere in 100 years, we're right back where we were. Obviously, we don't know what we're doing. Yeah. One more question? So I can at least say one more question? It's always fun to do. One more question.
What is the significance of a high systolic and a low diastolic?
Great question. Boy, that's a good one. So if you look at the data of what happens to adults, when you're under 55, men and women, their systolic and diastolic tend to go up together. When you start to become over 55, you see an interesting thing happen for both men and women. The diastolic starts to turn around, and the systolic keeps going up. And the reason for this is that we think this is related to the stiffness of their blood vessels at this point. So what we call the difference between the systolic and the diastolic is something called the pulse pressure. And the pulse pressure starts to widen for people as they get older. And so when you see this pulse pressure widen, you want to make sure, are there valves in their heart okay? Because that would be another thing that would cause, and that has to be fixed. But if it's not due to heart valves, it's probably because their blood vessels are probably becoming stiffer. I think that is I think in the end, if somebody does my experiment of taking people when they're young and not letting their blood pressure change, I bet you we don't see that anymore. I think that's already because there's some damage. So a widening pulse pressure, that is the systolic going up with the diastolic going down, has been associated with doing worse. That's why what we're saying is we treat people mostly based on the systolic. And the reason we want to do that is because when we treat the systolic, the diastolic doesn't change that much, but we reduce the pulse pressure. And that's sort of the basis of that. Again, when I was in med school, it was all about the diastolic. Now it's all about the systolic. Boy, where are we going next? So thanks very much. You guys are great audience of very advanced students. Thank you.